Good morning, everyone. As we're waiting for folks to trickle in to this wonderful Wednesday morning grand rounds, a reminder that we'll actually remind people at the end as well for all the clinicians to get your flu shots before November 10th. And I already had mine. Here come the slides. There we go. So we have a few announcements to begin. So as part of our inclusion round series, we will have another inclusion round with Dean Tiffany Steinwert on promoting spiritual wellness and inclusion. We've actually been planning this for several months, and it's quite timely. So that will be Tuesday, November 14th at noon. Next slide. And with all the ongoing horrors in the Middle East, community circles are organizing for the Stanford Jewish and Israeli community and the Stanford Arab and Muslim community. There will likely be more of these in coming weeks. This one is today. And next week, please join us in person for a very special grand rounds in memory of Brooke Gapster, who was a resident in our program who passed away. And we have Dr. Rick Hodes coming to present to us. It should be a very memorable talk as well. Okay, so I have the great pleasure of introducing our speaker today. So as you may all recall, October 1st was National Latina Physician Day, and we continue to bring you giants in this field as we turn our attention to how we at Stanford can advance the care of our limited English proficiency Spanish-speaking patients in the wake of this pandemic. I was told at Stanford that 80% of our interpreter uses is Spanish. So we have the great privilege of welcoming Dr. Rodríguez to share his recommendations with the community. Dr. Rodríguez is a graduate of UC Berkeley. He completed his MD at UCLA, followed by family medicine residency at UCSF. He obtained an MPH at Johns Hopkins, followed by a fellowship as a Robert Wood Johnson clinical scholar right here at Stanford. He is Professor Emeritus from the Department of Family Medicine at UCLA and was also Professor of Community Health Sciences at the UCLA School of Public Health. He has led multiple multidisciplinary collaborative initiatives to promote health equity. He was founding director of Health Equity Network of the Americas, which is an international network with representatives from 26 countries, founding director of the UCLA Blum Center on Poverty and Health in Latin America, and founding director of the AltaMed Institute for Health Equity. He continues work as executive director of the California Alliance of Academics and Communities for Public Health Equity and a senior advisor for the California Academic Health Department Project. His research has included topics of ethnic, racial, immigrant health equity, gun violence prevention, intimate partner violence prevention, primary care systems and global health, and healthcare workforce for the underserved populations. His consultation has been sought by the WHO, UNICEF, the Pan American Health Organization, the CDC, and the Institutes of Medicine. Without further ado, I turn it over to Dr. Rodríguez.
Thank you so much, Wendy. I greatly appreciate your kind introduction and kind invitation. This is an honor to be here. It brings back the fond memories of being there at Stanford and on Welch Road and working with the giants of Stanford or some of the giants of Stanford medicine. And so I'm going to share my screen here. There we go. And so, as Wendy mentioned, it's a pleasure to talk about language access for limited English proficient individuals, and how it is a matter of equity. This is something that I've worked on for most of my career. As many of you may be folks who have a language that you're able to speak with your patients who are non-English preference patients with regards to the care, and know when you care for somebody whose preference is to speak a non-English language, like Spanish, for example. I'll use Spanish as an example during this presentation, but certainly there's hundreds of languages that it could be. For me, what brightened my moment always was seeing those patients and their eyes light up when they saw and they realized that they had somebody caring for them who could speak to them in their language of preference. It was like having been in the desert and wanting water, and all of a sudden seeing water. It was quite a beautiful experience, but it underscores the challenges that folks have, and a quote actually adapted from something that Nelson Mandela said years ago, that if you talk to a patient in a language that they understand, well, that goes to their head. If you talk to a patient in their own language, you speak to their heart. And in my experience, and I think most folks would agree, when you can speak to somebody's heart, that's the pathway to gaining trust. And when your patient trusts you and the care that they're receiving, well, then they're more likely to share what's happening in their lives, give you the history, and work with you for their health. We'll circle back on those issues, but I always find sometimes a vignette, a clinical vignette, helps to highlight the issue. And so this is Mr. L, is a 74-year-old Spanish-speaking man with type 2 diabetes, hypertension, chronic kidney disease, decreased physical functioning, and limited English proficiency, who was admitted to an urban university hospital with progressive dyspnea. Upon discharge with a new diagnosis of heart failure with preserved ejection fraction, a medical assistant who was not a certified interpreter aided a nurse in conducting medication reconciliation and delivering discharge instructions written in English. Mr. L was readmitted 10 days later for heart failure exacerbation requiring assisted ventilation after self-discontinuation of diuretics due to polyuria and a self-reported minimal understanding of the rationale for recently prescribed heart failure medications. This highlights how adults and children, how people who have limited English proficiency or who prefer to be spoken to in the language that they're most comfortable are at increased risk for adverse events when medical information is not appropriately delivered. And it still doesn't do justice, because when you think about a case like this, and you think perhaps at that time when that patient was being discharged, the patient was probably under stress, couldn't communicate, couldn't feel like he could communicate effectively, worried that he is at risk for some problem happening because of the lack of communication, and unable to express himself, let alone his preference for language of communication. And one of the things that Stanford and most places strive for is the highest quality of care, which, as many of you are well aware, have characteristics of being safe, effective, patient-centered, timely, and efficient. And a cornerstone of this is this patient-centered piece. And that really, if you drill down, it's about being respectful of the patient's needs and preferences, including language of communication. And that those needs and preferences guide our decisions, our partner decisions. This is what patients who prefer a non-English language are challenged with every time they go outdoors, but most worrisome when they go see a doctor or have to be hospitalized. Considerable worry and anxiety over whether they're going to be able to communicate effectively. Nearly 68 million people in the United States spoke a language other than English at home in 2019, and 42 million of them were Spanish speaking. And more locally, the San Mateo and Santa Clara counties that Stanford serves is amazingly linguistically diverse, as is the Bay Area. Over 100 languages. Nearly half of residents speak a language other than English at home in these two counties. And when you drill down for those who could be characterized as limited English proficient, 1 out of 5. And limited English proficient in this case is being defined as less than very well, speaking English less than very well. That's particularly important given the flow of patients that you all see and that we all see, whether we're in the Bay Area or any other place that, which is most places, particularly urban areas. When talking about working language access, the realities are important to acknowledge, which is that family and friends too often are used as interpreters. And the problems, multiple problems with that, are that they can misinterpret or omit doctors' questions. They can particularly omit potentially embarrassing patient complaints. And sometimes the patient will also not disclose other information. For example, they may not disclose that they're suffering because of the abuse that they're experiencing by the hands of their partner, and because they have a violent relationship, a case of intimate partner violence. And so qualified medical interpreters, certified medical interpreters, make a big difference. And indeed, literature, which I have a list of at the end, increase the use of preventive services, help reduce medical errors, reduce hospitalization rates, and help doctors to understand cultural influences on health. And I would add, promote trust between us and our patients. And as a result, help to promote health equity, which I know is a big priority. So C. Belden from the Inclusion Solution quotes, "Equality is leaving the door open for anyone who has the means to approach it. Equity is ensuring there's a pathway to that door for those who need it." And that's a particularly important distinction, so that just having something is not enough. something that's available, like language access services. It is ensuring that everybody can be able to use it. And we'll get into some details there. But when people do not get adequate access, when patients who need it but don't get interpreters, they often have lower quality of care and higher incidences of adverse events. And some examples of that are listed here, with higher risk of non-adherence to medications, less likely to have regular source of medical care, more likely to leave hospital against advice, excessive ordering of medical tests, and higher rates of medical error, higher risk of surgical delays and readmissions, as well as decreased patient satisfaction. These are amongst the many problems that we find with patients who don't receive high qualified interpreters. This brings us to sort of who is it that sometimes that it receives, at least should receive some consideration, and certainly those who have limited English proficiency would be included there. As I said earlier, it is those who have an inability, some limitation in their ability to speak, read, write, and or understand English language at a level that allows effective interaction. And vice versa, our inability as individuals or as a system to be able to communicate with our patient. It's a significant barrier, not only for what I had talked about earlier in terms of the potential complications and quality of care, but being aware, for patients to be aware of their benefits, that they have access to, understanding their rights, being able to adhere to their responsibilities, understanding other information provided by federal funded programs and activities. And so it's particularly important. It's helpful to get a little bit of background for how language became an issue codified in law. And the Title VI of the Civil Rights Act Law of 1964 states that no person in the U.S. shall, on the grounds of race, color, or national origin, be excluded from participation, be denied benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance. Further clarification from the Department of Justice, 2002, stated that federally assisted entities are required to make reasonable efforts to ensure meaningful access to the programs and activities by persons with limited English proficiency. And so that's where that clarification came. Many people ask, well, what does it mean what is meaningful access? And it is language assistance that results in timely, accurate, and effective communication at no cost to the person who has limited English proficiency, or who basically prefers to communicate in a non-English language. The other piece that sometimes people ask about is the phrase in the first paragraph that says, any program or activity receiving federal finance assistance. Some people say, well, who are recipients of federal assistance? Federal financial assistance includes grants, trainings, use of equipment, donations, or surplus property. And they may include all these on this list: state, county, and local health agencies, hospitals, nursing homes, universities, state Medicaid agencies, etc. All of those and more, certainly. And so it's almost everybody, basically. The federal government has been working, particularly under the Biden administration, to address issues of equity and health equity in particular. Language access goals within that plan, the health equity plan, were set by the 2022 HHS Equity Action Plan, and that came out of the executive order advancing racial equity and support for underserved communities through the federal government that was issued shortly after Biden took office on January 20th, 2021. This year, the HHS Office for Civil Rights Language Access had published, in fact, earlier this month, they published this. Actually, it wasn't this month, it was a couple months ago. The Language Access Annual Progress Report, their first one. And as you can, I put in the quote that the purpose is to address historic failure to invest sufficiently, justly, and equally in underserved communities, as well as individuals from those communities. And the focus, the areas include in this equity plan is looking at language access in on the internet in terms of web pages and public information access, telephonic access, access to programs and activities, as well as related to federal funds to provide needed language services. So all of those are issues covered and addressed in this update, which you can see online, and outlines the direction that that HHS is going, as well as the federal government in general. So how do we move forward? What are some things to think about with regards to reflecting on systems and how we can intervene to address the needs of our patients that have a preference for non-English communication? Well, we can look at it in terms of patient-level interventions and system-level interventions. And important components of patient-level interventions include the identification of language preference, as well as appropriate use of interpreter services. And the system-level interventions include a focus on various different types of interventions that could help maintain high standards of care for our patients that have limited English proficiency. And I'll go over this in a little bit more detail. The key issue is looking at systems with regards to the identification of patients who may need the help. That includes screening, systematic screening, identifying and documenting language preference, so that it's known, everybody who comes in contact with that patient knows it and can act accordingly to optimize care. And using standardized questions for preference as well as for English proficiency. The appropriate use of interpreter services also is our patient-level interventions, and that help to prioritize language concordant care, of course. So ideally, patients who have non-English requests for communication can see a clinician who speaks that language. And if not, then we can have the documentation of having a patient who has a language preference that's non-English, and then be able to have that professional interpreter already assigned and aware of the need, and have that documented in the chart. And if a remote visit, certainly to have a preferred video as opposed to otherwise, whenever possible. System level interventions are numerous, and they start with assessing the community language needs. The same way that the systems need to identify and assess the community's health needs and other health-related needs as well. And this can be done through community health assessments if the questions are asked and the data is secured. And those are all routine periodic assessments that are done in order to assure that any changes in needs of population and communities that are served can be addressed adequately. Helping to inform patients of their rights to access language services, facilitating screening and tracking of language preference, and documentation of provision of interpreter services in EHR. The screening and tracking of language preference, that's because that can change. People change. People may, at one point, not want to speak in a non-English language, and then want to speak in a non-English language, or vice versa. And so that's why it's important to update their preference always, as well as their proficiency. Provide easy access to certified interpreter services, staff, and equipment. Train clinic team members on appropriate use of interpreter services. Ensure availability of the high-quality language concordant health educational materials. On the issue of language concordant, the issue also of ensuring connection with clinicians who also are language concordant are important. And our need as clinicians who may, for example, in my case, speak Spanish, there was very minimal amount of hoops that I needed to jump over to be able to document any kind of ability to speak that I could speak Spanish with my patients, and that's an area that we need to work more on, because clearly there's a wide range of our ability, even just those who are Spanish speakers or any non-English speaker, in terms of our ability, as well as being trained appropriately, which we'll talk about in a moment, so that we can communicate effectively, or communicate with our patients with regards to those patients who speak languages that we may not be able to communicate with our patients in. Ensure that the language appropriate medication labeling is provided. Ensure support. And I'll say a point of the language appropriate medication. One might think, wow, well then, if they're speaking Spanish and they prefer to speak in Spanish, then we should put a Spanish label on there, which makes sense. But we need to know and confirm that patients can read Spanish, because just because they understand Spanish much better than English doesn't mean that they're able to read it. And so many times our patients who speak languages other than English and prefer to communicate in that, many times they're also live with family members, and family members are assisting them with their medications. And sometimes those family members don't speak, in this case, Spanish. And so it's important to have that level of additional communication to clarify. Ensure support of the older adult patient and caregiver by having easy to read, understanding instructions, and also being aware of any helpline availability or ways in which they could contact should there be any questions or any concerns that are raised. Increased recruitment and training of healthcare professionals that can provide language and cultural concordant care. Certainly, that's a particularly important issue. For example, amongst Latinos, we know that we are now approaching half of the population of California, and yet physicians are approximately between 5 and 8% who are Latino, and only a subset of them who can actually speak language fluently. As well, and then, of course, facilitate certification of clinical team members in second language use when appropriate, with appropriate processes to do that. So these are just some examples of system-level interventions, not intended to be comprehensive because there's just not the time to do that. But to give you an idea of the kinds of systems that we can have to make our systems most effective and facilitate access to language access services for our patient. Training is important. It's amazing. We can have lots of policies, but if we're not aware of the policies, and if our staff are not aware of the policies related to, for example, limited English proficient folks and procedures, then that's another potential gap and another potential area. Ways in which we become aware of such policies are, of course, with training. Most of hires get a barrage of information about all the many policies that we're supposed to be aware of, and of course those are also can be very difficult and challenging and overwhelming to get in one dose. People have talked to me. I've actually felt myself that sometimes it feels like you're drinking water out of a fire hose when you have just so much information coming as a new hire. But annual trainings also help to underscore that, and there are other ways to augment. And so, but certainly being aware and knowing what are some of the policies can be very helpful. And also knowing our staff knowing what to do and how to respond with regards to in-person visits, as well as with regards to working with telephone interpreters. And so knowing those processes, knowing how to put them in place, knowing how to put them in place in an effective and efficient way, all of those require or benefit certainly greatly from training and policies and procedures that help to facilitate all these processes. Some basic tips, I guess, for working with interpreters, that are important to keep in mind. Frequently, when you have 3 people in the room, assuming that there's patient, interpreter, and clinician, it's easy to be looking at the interpreter instead of the patient or a client. And so that's really an extremely important practice. Not easy, and it takes time and effort to have the person, the interpreter, next to you, so that the patient is looking and can look at the interpreter, but also can be looking at you, so yes, you're next to each other, and then you're continually looking at the patient, and so the way in which we see each other or place each other helps to facilitate that process of maintaining eye contact. Of course, these days with computers, it also becomes challenging because we're sometimes, not sometimes, we're always on the computer, and frequently we're typing notes, and so that's also important to maintain that eye contact, to use simple language, and simple, not as simple as possible, and in short sentences, in this sentence by sentence interpretation, so that the interpreter has time to be able to interpret what we're saying. It takes longer, and it results in better comprehension of what we're doing. Using first-person statements rather than asking the interpreter to tell something to the patient. So really speaking to them directly to the patient. As long as we're doing it in simple language, in short sentences, and having sentence by sentence interpretation, well, then that can help to facilitate that communication in very effective manners, especially when working with certified interpreters. And similarly, when talking about complex medical issues, doing them in serial manner, one step after the other, and ensuring that patient understands by using the teach back method, that is asking them, asking them to please explain, or first if they understand, and also if they'd be willing, if they could please just tell you back what you made an effort to teach them, or to explain to them, I should say, and then sometimes rephrase things if the message is not understood, and always elicit patients' perspectives, how they're feeling, what they think, concerns, as that is a way of connecting, and a way of just one of many ways to enhance patient-centered care. Even when our patients don't understand a word that we say, we can show that we care. And one way is by looking at them, paying attention to their body language, responding to it, making an effort. They can see someone who's kind. And that kindness pays off big dividends, because that helps at least send the message that we care. And we care more about them than the computer or whoever may be interpreting, including the certified interpreters. So it's so important, this piece, especially when you have limited language abilities. So systems can also do things in the environment that can help facilitate this, an environment that's language access friendly. So sending the messages, right? And so those are giving signs in offices. Be prepared for when people who prefer non-English language communication make a call. And so that the person answering knows how to accommodate them. Translating documents, brochures, booklets, and other information. Could put the information in as a proud badge of language access alongside other information that's published about your systems, newspapers, radio, television, and other, certainly web social media. Partnering with community-based organizations and other stakeholders so that they can communicate. So they're aware, and so when they're working with community members, they can inform them of the services that are available at Stanford, for example. Many people get their information from trusted community-based organizations or people who work at these communities, because many of the people who work in these community-based organizations are from those same communities. That's what helps make them so effective, because they're people who are trusted and frequently people who understand the context in which their neighbors or fellow community members are living. Presentations at different venues, whether they be school, religious, and other community organizations. And then, again, the information on the website so that it's clear on the front page of the website that if you need or prefer to speak or to read in a non-English language, you can actually do so. The organization can reflect its commitment to equity and language access by, well, policies, procedures, or at least documenting what needs to be done. And below on this slide, you can see it's a variety of different policies, documents that could fall under this, including culturally responsive care policy, limited English proficiency policy, or language preference policy. The many people comment how limited English proficiency policy is a word that reflects a deficit and as opposed to a need, and can be interpreted in a negative way. And so that's why many folks also say and encourage framing it as language preference. So then that way there's more of a respect for what the patient wants. Interpreter services, procedures, etc. All of these are different ways in which organizations can organize and can document in systematic ways what needs to be happening. Now, we should at least consider in what ways we can evaluate or assess the impact of our efforts. And so some measures that can be looked at include percentages of patients screened for preferred language. What's the percent who receive assistance from trained interpreters at assessment and discharge? What percent wait longer than 15 minutes for interpreters? What percent of interpreters wait longer than 10 minutes for interpreters? Sorry about that, the error. How much time interpreters spend interpreting? And so you can also have length of encounters, percent of interpreters trained, etc. Percent of bilingual providers assessed for language fluency. This is what I mentioned earlier in terms of us also being assessed and accountable. And time interpreters spend providing other patient services. So all of these are just example of measures. The other measures include types of language services available and how staff can assess them. Finding and facilitating processes so that staff and clinicians can provide feedback. In this area of language access, there is a lot of potential gaps. And the sooner that those are identified, the sooner those potentially at least can be addressed and responded to. Ensuring that language service integration can be at important touch points, for example, during admission and discharge. So that higher priority of certain areas, making sure that the language services are provided. Knowing how to respond to written communications from folks who prefer non-English communication. The coordination between different systems. There's Stanford Medicine and there's Stanford Healthcare, and so Stanford Medicine may have all kinds of fantastic processes, procedures, and knowledge and systems. But Stanford Healthcare may not be totally aligned with all of them. So ensuring that there's this coordination on all this. And ensuring competency, of course, of interpreters and translation services. All of these are extremely important pieces. It's process of evaluation and assessment is very important, as it is with other areas. But this one particularly, I have to say, is, I think, historically has not, I haven't seen it having the priority that it needs to have in order to ensure that we're doing the best we can to provide the most effective, high quality care possible. And that's why the equity piece is so important. Promoting health equity for limited English proficient patients at the system level, it really means that language access team or the representative has a seat at the table. And so we all know that there's many different meetings and efforts that happen or strategic plans that are developed. Well, when we promote health equity for our patients who have non-English preferences at the system level, that means that language access does have a seat at the table. And when health equity is an organizational priority, interpreters will be treated as an essential service.
About any plans to.
And that is a significant shift in the ways in which interpreters, language access systems are treated in general. But I think it's the bar that will help actually shift to have a higher proportion of folks, to have everyone, this is the whole point, is that when we treat those services as essential services, well, then we start to think that this is something that every patient has to have access to, or at least to be identified to see if they are available, if they need it, language access services, if they want language access services. And so this is the part where we need to create those pathways so that the language access services that are available are accessible for everybody in ways that are easy, in ways that make those decisions, just facilitate them in ways that help to promote the likelihood that they will get them. This is the equitable way. And this is the way that provides just and equitable access to highest quality of care. And so on that note, I want to thank you and provide some time for any questions, any issues that I brought up, and any that you have thoughts about, and any other ways that we can work together to help make a difference. There's some of the resources, and all of this will be made available. So I see there's chat. I didn't have a chance to sort of take a look at the chat, but I please do welcome you all to let's see.
Yeah, I could help moderate. I will moderate the questions.
Okay.
So thank you, Dr. Rodriguez. That was a great introduction for the whole system in terms of what can be done on the individual level with the use of interpreters, but what really can be done on a systems level. So we have a lot of questions that have come in. So I'll start by turning it over to my colleague, Angela Rogers, to ask a question live.
Thank you so much for a wonderful presentation. I'm an ICU doctor and I speak Spanish. I did medical Spanish and Spanish in college. And so for my big conversations in ICU, I always use the interpreter, you know, for end of life or formal family meetings, but enjoy my personal interactions. I think that personal connection with my patients seems good to do, and it just with me talking. And I wonder if you can speak about, but I will say my fourth year high school student is like, what is that conjugation? What do you think you're doing there? And so I'm just wondering if you could speak about formal certification for providers, or just a semi-often assessment of how we're doing to give us feedback. Does that exist elsewhere? Is there a gold standard for that?
I'm not aware. I know that it exists in many different places, and there's many different programs that exist. But unfortunately, it's inconsistently implemented, and it's not even recognized in many different places. And so that's why I raised it as an issue, because there's such a wide variation. I think what you do, Angela, is so important, because even though we should in many instances have a trained interpreter, just seeing that effort, just trying to make an effort, saying a few words, it doesn't matter whether it's conjugated in a certain way or not. If it was my mom, she wouldn't even know the difference, but she would appreciate the smile, the effort. Those things are really important. At the same time, for a quality of care issue, and kind of having a sense of what's going on, that's really important, because sometimes people take on more than they should. Mm-hmm. And that sometimes is an important way to sort of have consistent. I don't know if anyone else is aware of any other sort of programs. I'm not sure if Stanford has a program, but I do know that they exist, and I could get back on that specific question as well.
Thank you.
I think there's a lot of systems. There's a lot of questions relating to them. I do know that we have a certification process, but I think, to your point, making sure it's facilitated for all members of the hospital staff to be able to access it. So a few more system level questions here. So a lot around CMS. So social, you likely know the social drivers of health measures are new required CMS measures. Do you think CMS may have a measure that's identification of patients with limited English proficiency or a measure on the documented use of interpreters?
Yes. Yes. I'm there are many there. And the process, the limited English proficiency question is a census question. And so that's a question that's answered, asked of people who fill out the American Community Survey periodically. And so it's like a sort of a very brief question, and so I could share that if needed. So happy to do so. What was the other question?
If there was a documented use of interpreters, is that going to be a measure?
Oh, yeah. I think, well, I think it's an important measure for any system to take track of, definitely. And so whether CMS will sort of the degree to which I would imagine that CMS has it, because this is something that is one of the highest priorities for the administration as well as for HHS. And so they're really pushing it forward as reflected by, well, the executive order and then the different efforts that are being done by civil rights divisions within HHS. But I'm not specifically aware of any particular ones of how to do that. But I can get back about that as well.
Right. There's some follow-up questions around funding. I think a lot of people think about the time it takes to have it with an interpreter. So are you aware of any payers or CMS that's allowing for increased payment? Or, a lot of worry about the institutional tracking of RVUs and how it does to account for the extra time to use interpreters.
Yes.
So I don't know if there's going to be modification of RVU compensation. You're note that there are systems, and I believe in Los Angeles too, that actually
All right. No, those are
language certification get paid extra.
so. I agree. I mean, from somebody, I worked in the refugee clinic at San Francisco General Hospital, and so constantly sort of worked with that. As well on the wards as well as outpatient, and so the challenges with translation and interpreters and the cost and the time, especially when those of us, especially on whenever we're always trying to balance things out, provide good care, but at the same time get a lot of things done at the same, and so. When you go to that document that I had pointed out that HHS came out with this year, they have a piece on funding. So and so the answer is they're working on it right now, and so they recognize that it's an issue. They recognize that it's a barrier, and so they're working to see in what ways it can help to be addressed and responded to effectively. I think some of those things, and the literature sort of responds to this in a way to sort of say that there's cost in these other services. There's also costs in not having those services. There's a cost in terms of the quality of care we provide. If we're concerned and we want our patients to have satisfaction, then we need to sort of provide things. If we know that translates into them helping to provide us with better information, then we do it, right? If we know that it produces complications, readmissions, potentially deaths, preventable deaths, boy. If it were any other issue, if it were a technical thing that was needed, in a heartbeat. And so I think it is about issues of how we look at this and whether we look at this as an essential piece of how we do business or not.
Speaking of technical pieces, there are a few questions on AI interpreting.
Yes.
And Alicia Fernandez a few weeks ago showed us some examples in her research where sometimes AI leads to interpretations that are incorrect and potentially harmful. But do you think if it is achieved, do you think it'll be adequate to meet the needs?
Well, I have no doubt that AI in some way will be used in this space. It will be used. There's again, this language access is translation, right? Is of documents, and so you can imagine how even that function, right, to automatically have so many documents translated in such a quick amount of time. It doesn't mean that you don't need to review it and make sure that it's accurate, but it can be extremely helpful. And diagnoses. I mean, there's so much of this that's going on right now, and so. But I have no doubt that they will continue to tweak on it and work on it. But certainly, the issues that Dr. Fernandez brought up are critically important. There are biases. There are, as we know, there are ways in which ChatGPT makes up things, okay, that don't exist. All right. So we know it's one thing when you're just, finding some general information, is a whole nother thing when you're caring for people and making clinical decisions based on that information. So, and then there's also this issue of, the body language that you get, right? What are the cue, or these other cues that come out that are not as easily interpretable. And some of that is interrelated with this whole, right, this power differential that we have with our patients. And so sometimes those things, they cause you may get a response, but you may see some hesitancy. You may be able to interpret, wait a minute, there's something here yet. I think they're holding back or whatever. And so that's really important. All those are very critical nuances that we don't always see. So I'm sorry I went on, but I realize there's a lot of other questions. I'm happy to address them afterwards and in written form as well. So.
Yeah, thank you so much. Well, on that wonderful note, we will end. I just want to remind everyone as a primary care physician to get your flu shots before November 10th, since it's also a requirement. And thank you again so much, Dr. Rodríguez. I'm sure we will continue to work closely going forward as we work to do this work here at Stanford.
I look forward to serving Stanford anytime. Certainly a pleasure that's warms my heart always, and I wish you and everybody else the best.
Thank you.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.